There are a lot of patients that will receive surgery to remove a
Hmm.
polyp. They return to the same habits that led them to develop the polyp.
What would those behaviors be in that case?
Some patients just speak loud all the time and they're just used to it. And they say, my family's like that. We all kind of scream at each other. We all yell at each other. And I yell at the dogs. I yell at the kids. And they're just used to it, but they don't realize that they're just have these behaviors where they're using the vocal folds so aggressively.
Hello, this is Anthony Effinger. I'm the host of the Think Neuro podcast at Pacific Neuroscience Institute. And today I am talking with Romina Huerta. She is a speech language pathologist at PNI, and she specializes in the treatment of voice, cognitive, and swallowing disorders. Romina, thanks for joining us.
Thank you for having me.
So tell us how you fit into PNI.
Ooh, that's actually a pretty big question because PNI is huge. As you know, we're very collaborative. We have a lot of different specialties here. Speech pathology specifically, there are two of us, and we are part of ENT, otolaryngology. So our ENTs will see patients who have any kind of complaints about voice or swallow. And now we also receive some of our patients from like neurosurgery who have some kind of, difficulty with their brain, cognition. We get some patients who have dementia, Parkinson's. So although we are mostly ENT, we are also seeing patients who have neurological disorders. And with them, we work on cognition, speech, swallow, and with ENT, we work mostly voice and swallow. So it's a little bit of everything, but really the big domains that we hit are voice, speech, cognition, and swallow.
Okay, so two terms let's define here, just because I like to say the word otolaryngology. Did I say that right?
Yes, you got it.
Okay. Remind our listeners what that is.
So an otolaryngologist is a doctor who specializes in ear, nose, and throat, hence the ENT. They're more commonly known as ENTs.
Okay, and an ENT is ear, nose, and throat. Okay, so they're interchangeable. Those terms, basically.
Yes.
Okay. So now you work with them mostly.
Yeah, and the way it works is the doctors, they see the patients, they diagnose, they provide medication, surgery. So that's where the doctors come into play. Now, when they have patients who they believe would benefit from treatment or therapy, that's when they refer them over to us. So they have some patients that, you give them medication and they're going to be fine. Some patients, they really don't need a lot of medication even. They just need to maybe modify their diet, do some things on their own. And those patients go home and they're fine. But for the other patients who need treatment, who need to work on certain things, they send them to us. So we are really in the therapy realm and we see the patients for an extended period of time to help them, reach their goals, which for the most part is to get back to their baseline.
Okay. Give us a few examples of cases you see with some frequency.
Well, with the ENT team, we get a lot of patients who are professional voice users. And me specifically, I see a lot of the voice patients. So for example, I get a lot of teachers. I get a lot of workout instructors, people who are constantly using their voices throughout the day. Now, a lot of these patients either have developed habits that are not ideal for their voice, so they speak with excess tension, or they just do a lot of behaviors such as yelling, raising their voice, things that are not really good for your vocal folds. And they end up coming to see us because they have voice problems. And most of the time when they come, it's when it's impacting their daily life, their communication, and their work as well.
Okay. Vocal folds. Are we talking vocal cords? Is that the same?
It is, people use it interchangeably, vocal folds, vocal cords, and actually different doctors will use them interchangeably, or some prefer one term versus the other. I believe I've been seeing most ENTs like to use vocal folds nowadays versus vocal cords, but It essentially means the same thing.
So this is the cutting edge here. We're changing some terminology. Why the word folds? Is that what these things look like?
Yeah, so, and I even have a diagram back here. I don't know if you can see it, but basically the folds are two muscles. They're covered with epithelium, which is just kind of like a layer of tissue that covers them. But they're two muscles. They are right here where you have your Adam's apple. That
Yeah.
is the larynx, which is also known as voice box, Adam's apple. So in there, you have these two folds that really are muscles, and they are the vocal folds. So they're muscles that come together and vibrate to produce sound.
Hmm.
Their function besides sound also is to protect the airway because it's at the top of the airway. Hence why we also see patients who have swallowing disorders, also known as dysphagia. A lot of these patients, when they have dysphagia, they're either choking on food, they're not able to eat certain consistencies. And if the doctor goes and he sees what's going on, a lot of times they'll refer to us and we work on modification or even strengthening for the muscles of the swallow.
Yeah, that's the thing, right? I've talked to your colleagues about this. They do two really important things: help us talk, and then also, like you say, protect the lungs and allow us to swallow.
Yes, precisely.
So they're kind of, yeah, and that's a big deal, right? I mean, swallowing becomes a big issue. I know when people get older and have, is it stroke?
Yeah, I mean, and more than just stroke, patients who have neurological disorders such as Parkinson's, like you said, patients with stroke, patients with brain injury. There are so many different reasons why people develop, issues with their swallows. Sometimes they're related to weakness, and sometimes they're related to neurological deficits. And every patient's unique. Sometimes the deficits are more in the pharynx, which is, kind of the neck area. Other times you have primary deficits in the oral area. So people who aren't really able to chew down or, propel the food backwards. And then sometimes a little bit lower, you have people kind of like right above the esophagus. So like the upper esophageal area where it's just not coming down and it's getting stuck there. So even then, we always have to see what phase of the swallow or what areas are we really working on.
And what do you do for those patients? What are the techniques that you have?
Well, depending on the patient. So for some patients who we know this is the best they're going to get, they are not necessarily going to be able to, have their swallow go back to how it was before the whole issue started. We work on compensatory measures. So for example, for some patients, we need to have them take smaller bites. So a lot of these things are very, I would say common sense, but sometimes people just don't think about it. So taking either smaller bites of food, smaller sips of liquid, and another one that's really easy, just alternating between liquid and solid. Sometimes people will say, well, I don't really drink throughout my meal and I feel stuff getting stuck. But when you have them take a bite and then alternate with a sip, it makes it a little bit better. Other patients, we even work on strategies such as a chin tuck, where you have them kind of tuck their chin and, hold the food in their mouth and then swallow it. That helps for patients who maybe will take a sip and then it just immediately goes to the back of the throat. So there are different strategies that work for different people. For other patients who are candidates for, recovery, or we can see strengthening, we work on exercises. So we really work on strengthening all of the muscles or where they have their deficits. And we hope to see some kind of improvement. And then we hope to see them upgrade their diet. So instead of eating certain consistencies, get back to eating whatever they want.
Yeah, makes sense. My mother had a stroke, and what you just described is exactly what they did for her.
Oh, I see.
Yeah, that's very familiar. And
yeah, I'm sure you had a lot of experience with that.
Yeah, it worked. And swallowing is, goes without saying, is a big deal, right? I mean,
it is a big
that
deal.
becomes job one to fix after a stroke. I know that.
Yeah, and it's very, very personal. I mean, sometimes people would say, I would rather have a voice disorder than to not be able to eat what I want. So food is so connected to pleasure and quality of life. It's very important.
Now, you are a professional violinist and singer, isn't that right?
Yes, that's right.
Okay, so what came first? That or this?
My life as a musician, I'm still a musician. I still
Yeah.
work as a violinist and singer. That came first.
Yeah, I
So,
figured. When did you start playing the violin?
I started playing, I think I was about 7 or 8. I'm trying to remember exactly, but it was around 7 or 8. I was in elementary school. I picked it up at that time. I picked up a couple other instruments too, and then I started singing, but I really just kind of decided to stay with the violin.
Nice. Now your band's been nominated for a Grammy, is that right?
Yeah, so my band, we're an all-female mariachi ensemble. Our name is Mariachi Reina de Los Angeles. The group has been around for, next year would be our 30th anniversary. The group has been around for 30 years now. So, it's known as the first all-female mariachi ensemble here in the US. So
Wow.
throughout the years, there have been different albums that have been recorded, and we have some albums that were nominated for Grammy. So have not won a Grammy yet, but hopefully in the near future, that would be great.
That's fantastic. Now, do your fellow musicians ever consult with you on voice issues?
Yeah, I think from time to time, people will ask me, like, my throat is feeling a little funny, or what do you recommend for this? What do you recommend for that? People will come from time to time. I try to let them come to me. I never like to give unsolicited advice. I think nobody
Sure.
likes unsolicited advice, right?
No, well, no, but yeah, but if they find out they got an expert in their midst, right?
Yeah, and they do. They'll ask me for certain, techniques or things that help, especially when they're recovering from a cold or something like that. So
Yeah.
it's pretty cool.
Yeah.
It's nice that it's very connected.
Yeah. And you said you see other musicians and people who use their voices. Is that right?
I do, I do, I do. I get a lot of singers, actors, people who do like voiceovers, audiobooks, and of course, all kinds of singing styles. So I think, the coolest part about being a speech therapist and working in this capacity, people really appreciate that, I'm a musician. They understand, or they feel that I understand them. And to them, it kind of, it helps me connect on a different level. So I think that's the coolest part of doing this and having had a musical background.
Well, I was going to say, right? I mean, you know where they're coming from.
Yeah, I totally get it.
Yeah.
You can't tell them, "Oh, well, you can't work this weekend." It's their livelihood, you know?
Yeah.
Sometimes we do have to tell them, you're going to need to plan for these many days of voice rest, like if they have a surgery or something. But, sometimes we just have to work on modifying and doing our best to work around it, because at the end of the day, they're going to get out of here and they're going to go gig. So we have to be realistic.
Yeah, totally. I saw a concert up here recently, and this band, My Morning Jacket, and the singer has got this incredible voice, and he was, using it so aggressively is not the word, but I mean, he was really belting it out.
I
And
see.
he's on tour, and I'm wondering how is he able to do that? Like, what does he do? What is he doing, and what are you probably doing with the musicians like him between these gigs to keep them in the game?
Well, I have this conversation all the time with my patients. I have some patients that'll say, well, I worked 3 hours and that was a lot. And I'll tell them that's not a lot. We have these people who tour and they're singing, multiple hours a day, every day, people on Broadway, people who are on tour. And like you said, they're not singing, with half effort. They're going hard every night, every time they perform, they're giving their all. So a lot of these people, and it's interesting, like singers have such, particular little habits here and there. For example, one of the things that my patients really love, and I've seen a lot of singers do, is using a nebulizer. So they have these portable nebulizers with a saline solution, which is basically just salt and water.
Mm.
And you put it over your mouth and your nose, and you're kind of breathing in the steam. So as you're breathing in that steam, it's directly going into the vocal folds and just kind of giving you some extra moisture. That's helpful when you're tired, when you're a little bit irritated, or when you're dehydrated. So,
Wait,
that's
why? Because when you're tired, because it's not functioning as well, then?
usually when you're tired, you stayed up late, so you didn't get enough rest. And you probably talked a lot. So if you're awake for more hours of the day, you're probably talking for more hours of the
I see.
day.
Okay, okay.
So you're using your vocal folds a lot more. Or if you're tired because you sang a lot the day before or you talked a lot the day before, The folds might be a little bit irritated from overuse,
Mm.
so tiredness, overuse, they can be hand in hand.
So every time I talk to some, like you talk to we're talking, rookie, regular, people in the world, not professionals, but it was like, lemon and honey, lemon and honey. Is that a myth or does it work?
I wouldn't say it's a myth per se. I think everybody has different things that feel soothing to them. I know some people love throat coat tea, for example.
Oh,
Have
I've
you
heard of
heard that
that.
one? Yeah,
Yeah.
and they have these ingredients like glycerin is a very moistening type of, agent. So a lot of these teas that have glycerin, you're drinking it and it does give a moistening effect and a soothing effect. Lemon and honey as well, they kind of give you like that coating effect. So it does
Yeah.
give you temporary relief. I wouldn't say it's a myth,
Okay.
but
All right.
I do think some things might be a little bit more soothing than others, but some people love the spray. Have you ever seen those singers? They have sprays. I think some of them are herbal. I tend to not recommend things like menthol, things that are very herbal. So, for example, cough drops. Those are very, they have a lot of menthol, a lot of herbs. Have you ever had like Ricola cough
I
drops?
just that's immediately what I thought of. Yeah.
Yeah, so those are great for suppressing a cough. And a lot of times they kind of give you like a cool sensation and they dry out any kind of excess mucus in a way.
Yeah.
It helps suppress the cough. And I think the menthol also kind of is supposed to, the sensation of soothing pain. But in the end, menthol can be very drying. So a lot of speech therapists that work with voice, we recommend either, drops that have or lozenges that have glycerin or pectin.
Pectin.
Yeah, those are the
Okay.
really
Okay.
moistening ones. And they're good for just everyday throat irritations, especially for all those throat clearers, the
Oh,
compulsive throat clearers.
yeah. Yeah. Okay. Okay. So that's good. That's good. So, do you see people who have used their voices so much that do people get like scarring?
We have patients who, if, for example, let's say that, you know, I have a lot of, actors.
Okay.
And there are some people who maybe have to do a scene over and over and over. And if that scene requires, yelling or screaming, anytime that you're yelling very loudly, the vocal folds come together very forcefully. So they're not designed to be coming together forcefully over and over and over for extended periods of time. So in that way, people will develop hemorrhaging. And sometimes, it can lead to like a polyp. Over time, it could lead to scarring. So it can happen. It usually takes time though. It won't happen from one event that you'll get scarring, but you can get hemorrhaging and swelling of the vocal folds.
Funny you mentioned that because one time I was at a sporting event for one of my kids, and I'm going to embarrass myself a little bit here, but they asked us to yell really loud, right? He was in a rowing event, and they said you got to yell as loud as you can,
Hmm.
right? And I yelled so loud that something broke. Like
Oh, you
after
felt something?
after I yelled once too loud, I could not. My voice changed, temporarily. I mean, it's still not great, but it something like felt like it popped and I could no longer yell. What is happening there? Is it like you pull this muscle or something?
Well, remember that the vocal folds are muscles. So
Yeah.
in what you were feeling, it could have been that you felt hemorrhaging. And anytime you have, any kind of swelling or hemorrhaging on one side, it disrupts the wave. So the vocal folds, they move in waves. So if you disrupt the wave, it's not vibrating the way it usually does. And that's why you feel that disruption. Like, it's not working.
That's it. That
Yeah.
makes so much sense. So when you say hemorrhaging, you mean bleeding?
Bleeding. Yeah. That
Wait,
can
like
happen
in your throat or
in the vocal folds themselves. So
oh
remember,
God.
there's like a little covering on the
Yeah.
outside. So the covering is the one that, you could see some hemorrhaging.
Yeah, I think
I
that's
know
what
it sounds kind of scary, doesn't it, when you think about it?
Yeah, no, but it's actually, that's the word that you said that prompted me to think of that story because it just felt like something had gone, it felt like I'd kind of skinned my knee,
I
or something
see.
like, oh,
Yeah, anytime you
So,
have, any kind of impact on that outer covering, if there's swelling, if there's irritation, it disrupts the wave. So anytime that the vocal fold wave is disrupted, they're not functioning the way they are. And a lot of times people will end up kind of pushing to get their voice out, and then they end up forcing over extended periods of time. People can develop muscle tension from speaking that way.
Hmm.
So it's very common. I see many patients with muscle tension dysphonia. So they either have some kind of issue in the vocal folds, they're compensating by really squeezing with the other muscles surrounding, and then that ends up just being their normal. But of
Yeah.
course, it's not a natural way of speaking, and that's why they end up with a dysphonia and they come here.
Dysphonia.
Yeah, which is
Yeah.
basically a voice disorder.
Yeah, that makes sense. So, what percentage of cases that you see are caused by, let's call it, mechanical issues, in the throat? And what percentage are derived from
Other
neurological issues? Is that a fair question?
Yeah, and then
Okay.
we see a lot of age-related vocal fold atrophy as well. So I do get a lot of patients who just have weaker atrophied vocal folds, which are muscles, just from being older.
Hmm.
It's very normal that over time the vocal folds can become weaker. They can become more kind of like bowed like this. So the vocal folds should come together this way, but over time, if they're weaker, you kind of have an opening. So when you're speaking,
Hmm.
there's air coming out and you kind of sound like this because
Oh,
you're not closing that gap. It's just air leaking out, you know? So I do see a lot of patients, and I think that probably boils down to patient population. So here in Santa Monica, I've been seeing that we have a lot of older patients, very healthy patients in their 80s and 90s who are doing pretty well, but they just have age-related vocal fold atrophy. So they come here and we work on strengthening because they want to improve their communication, improve their
oh,
voice.
sure. Yeah.
And when I mean percentage wise, it really is kind of the luck of the draw. Like
Hmm.
what are we gonna get in here today? There's, sometimes where you just get a lot of or neurological, we just get a lot of neurological or age related.
Hmm.
When there are times where I'm mostly getting these patients who are coming with these behaviors, these maladaptive behaviors, and I don't think that you can really put a big percentage on it
Okay. No, that
that
answers
I
the
can give
question.
you. We could probably look at it throughout the
Oh,
year, but it really is just kind of like
yeah,
what are we gonna get today? It's like patient roulette in a way.
sure. And did you say, or did I imagine that you said that you sometimes get people who are recovering from um, brain surgeries and things like that who need help with voice or not?
Yeah, I think, the majority of patients that I see who are recovering from any kind of, injury to the brain, whether it's traumatic or non-traumatic, most of those patients I see for cognition. So a whole nother thing that we do in speech therapy is we work on, cognitive therapy, which would include memory, problem solving, executive function, attention. So the majority of my patients who come with anything brain related usually are for cognition.
Okay. So I had a friend, this is a crazy story. He went on the bumper cars uh,
Mhm.
at an amusement park, and his head got snapped back when somebody hit him from behind, right?
Oh, yeah.
Okay. And it tore an artery in his neck. It tore the inside sort of layer. And
Yeah.
that eventually, over a few days, blocked blood flow to his brain.
I see.
And he's fine now, but he had to do maybe a year or more of trying to regain his ability to speak. He
I
could
see.
think, he knew what he wanted to say. He was all fine that way, but he could not get it from his head to his mouth. And
I
he had to
see.
do I mean, it was amazing what this guy went through. Do you see that sort of, do you help there too?
Yeah, of
Okay.
course. And it really, like I was telling you, it depends on the patient. I have some patients, I seems like what you're describing is that your friend had aphasia, which
Mm-hmm.
he knows what he wants to say, but he can't find the word. Does that sound familiar?
Yeah, no, totally. Yeah, that was it. And I guess I think what he was trying to do, and tell me if this is correct, is find another pathway, have his brain build a new neural pathway. Is that correct?
Exactly. Yeah. And
Okay.
it's that whole concept of neuroplasticity. So the brain is amazing. if you have this pathway that was, oxygen was deprived, usually you have necrosis, which is death of tissue. And once you lose any kind of cells in the brain, we don't regenerate those, unfortunately. So what the brain does is with therapy or with, treatment, they end up developing kind of like another way around that original pathway so that you can still access that information and use it the way that you want.
Yeah, which is fantastic.
It is. It's fascinating. And
Yeah.
I love working with aphasia. It's one of the things where it's so interesting to see no two patients with aphasia are alike. And it's so interesting to see, I have a patient who he has difficulty naming simple things. Like if I show him a picture of a pen, he cannot say pen, but he will say something like, it's a mechanical device that you utilize for, writing down information. So he'll give me this very, very, drawn out and eloquent answer, but he cannot say pen. And that's just the way his brain works, that he he had this amazing vocabulary before he went through what he went through. And every patient is different. So it's very fascinating to work with anyone with any kind of like brain injury.
In that example, is that because he can't say the P sound or he just can't get that particular word?
This specific patient has aphasia, so he just cannot recall the word for the thing.
But he can get he can get this elaborate description.
Yeah, like it's almost like they call it a tip of the tongue phenomenon, where you have the word here, but you just can't think about it. So, and there are so many strategies and so many therapies that we do to help the patient work around the word to eventually retrieve it.
Fascinating.
So, yeah, it's very fascinating. Aphasia is it's very puzzling. And like I said, no two patients are alike. And then I love working also with people who are bilingual and have aphasia, just because I bilingual in Spanish. So for those patients, sometimes they'll emerge from a stroke or a brain injury, and they're using their dominant language a lot more, even though they haven't used it for years.
So say somebody grew up with Spanish first.
Yes.
And they maybe speak English on a more day-to-day basis.
A daily basis.
They'll be more comfortable now using Spanish?
Yeah, I have seen that where they can't find the word in English, but they can find it in Spanish.
And that's why we should all be bilingual.
Yeah, I don't disagree. It's amazing. And it's also really good for the brain. It's a great, way to use your brain. Anytime you have you extend your like vocabulary, whether it be in one language or another, you're almost like expanding your brain capacity because you're seeing the world in two completely different ways,
Yes, I've heard that. I know a guy here in town. I'm in Portland, Oregon, and I know a guy here in town who was disappointed because he couldn't get his kid into a school that would teach him German, because he's from Germany and he wanted his kids to speak German. So he actually went out and started a school.
Wow.
Yeah.
Well,
and he was like, this is why, because he's like, this is so important that they be bilingual. And so, yeah, both of my kids took Spanish all through high school, and
that's great.
Yeah, they love it. And this, it's amazing stuff. Your colleague Carol Park couldn't be with us today because she's got a cold or
she's not feeling well today, unfortunately.
Well, COVID's going around. I hope it's not that. So tell me about her work and how you work together.
Oh, well, Carol, I gotta definitely say, is an amazing clinician. So Carol really specializes more in swallow. And when we're talking about specialties, as you can tell, there is so much to speech pathology. So much, just from what we've been talking about. We're working on voice, we're working on swallow, we're working on cognition. And that's just on the adult section. We also have speech pathologists who specialize in, working with children with feeding disorders, language disorders. So, it's always, as you continue to go up in your career, it's good for you to choose a specialty or to try to kind of narrow it down, because you can learn more and you're just better equipped to work with patients when you're specialized. So for me, like I said, I work a lot with cognition and voice. And then I also see patients who have swallowing disorders. Now, Carol, she has a really amazing background with working with dysphagia. So one fascinating thing that she does that I don't work on yet are patients who are laryngectomy patients. Laryngectomy is a patient who has the entire voice box removed.
Oh, wow.
So a lot of times, unfortunately, it could be, related to cancer. So they just completely remove it. So these people essentially do not have vocal folds anymore. Now, there are these, fascinating ways that we can still get these people to produce a voice and communicate. And what Carol does, and the kind of patients that she works with, the laryngectomy patients, they put in a tracheoesophageal puncture, which is
Oh my.
basically, yeah,
Okay.
or TEP for short, if you want to.
No, I like it.
Yeah. So with the TEP, you're placing it, in between the trachea, which is the airway, and the esophagus. And then, essentially that helps the patient to be able to produce a voice with the vibrations of the neck. It's very
Wow.
complicated. I'm trying to put it in as
No,
simple,
you're doing a great job.
yeah, simple as possible. And I mean, and that's not something that I have experience with. So whenever I've seen Carol go in there and just help the patients clean and remove and put in a new TP, it's amazing, and amazing that her patients are getting such good voicing. It's a whole specialty within our specialty, I would say.
And it's a complete workaround
Yes.
because these people do not have vocal
Any
folds.
vocal folds.
Okay, so this is wow. And okay, so I thought, this is my ignorance. I thought the trachea and the esophagus were kind of the same thing, but they're not.
It's okay. Honestly, the majority of people do think that.
Where do they split off? Or I mean, you go down here,
I know. It's so right at the where you have the larynx or the voice box.
the Adam's apple.
That's kind of where it splits. So one opening goes into your lungs, the trachea, and the other one
Okay.
in the
Okay.
back. Which is
Okay.
why sometimes when people eat or drink too fast, they say, "Oh no, I went down the wrong pipe."
Been there, done that. Okay,
Yeah, I
so
think
what
we all
you
have.
described is putting in a device between
Yeah,
the trachea and the
between
esophagus.
the entrance to the airway and the entrance to the esophagus. So they share a wall essentially.
Yeah, sure.
So it goes in there, and of course, then they end up having a stoma. So it's just a hole in the throat. There's something that they put on the stoma, and when they, cover the stoma, they're able to produce sound. It's amazing. It really is amazing. And these
And it might take
patients,
some training, right?
yeah, I was going to say these patients require a lot of continued care. So there's training about how to clean it, how to keep up with it, how to use it, how to troubleshoot it. So, she really does work with them. It's amazing to see her do this. So she really has kind of embraced this specialty. And the reason that we see a lot of these patients is because, we have a lot of head and neck cancer patients who come here to our ENT department. But Carol also works with, patients who have all kinds of swallowing disorders, all kinds of dysphagia. She works a lot with Parkinson's patients who have a hard time, being loud or eating. But also whenever we have too many patients on our waiting list, she will also see our voice patients as well. So we both essentially have the training and the ability to see all of these patients, but we're attempting to really kind of have certain patients go to her, certain patients go to me, just so that we can better, use our talents and our abilities, I would say.
Wow, well, we could do it. We'll do a whole podcast with her about that.
Yeah, I mean, I think
procedure.
you definitely, because she can,
Yeah.
it's a whole podcast on its own,
No, that's fascinating. How long have we been able to do that?
Wow, that's a good question, because I know it's been since I was young, I remember hearing people speaking with the electrolarynx. So
the thing that you hold up to your throat.
Yeah. And
that was made famous by a couple of movies, and I think that's what people think about when
they think about it.
Yeah, but that's
So man, I can't really say. I would be giving you a wrong answer, and
we'll explore that. We'll explore that.
Yeah,
That's
maybe Carol would be able to tell you, but But
Yeah.
I mean, I am very just as fascinated as you are with all of these advancements, all of these options that we have for our patients, you know?
Yeah, no, because I mean, so my mother, was Sicilian and loved to talk, and if she had lost her voice, that would have been it.
Oh, yeah.
She actually, I was going to ask you about this too. She had, I keep bringing up my own personal stories here, but
But it's
she
great.
had often had polyps on her voice box. It made her voice very gravelly, and then they would remove those. Are polyps on your larynx? That's a thing, right?
Yeah. And a lot of times, one of the great things about being collaborative here, there are a lot of patients that will receive surgery to remove a
Hmm.
polyp, but when the surgery is done and over with, they return to the same habits that led them to develop the polyp. So that's the cool thing. That's where we come in, where we help these patients. We figure out, okay, what were you doing to get you to this place where you develop polyps?
What would those behaviors be in that case?
Some patients just, for example, I have a couple patients that speak loud all the time and they're just used to it. And they say, my family's like that. We all kind of scream at each other. We all yell at each other. And I yell at the dogs. I yell at the kids. And they're just used to it, but they don't realize that they're just have these behaviors where they're using the vocal folds so aggressively.
And that causes the polyps.
That can
Oh my
cause
gosh.
polyps. It can cause nodules.
Yeah, yeah.
Attention dysphonia. It can be very different things, but yeah, and these are just habits that sometimes you don't even realize it until someone points it out.
Totally.
Yeah,
Yeah, no, I
so
could totally see that. And I'm going to guess that you're going to tell me that nobody should smoke if they want to take care of.
oh yeah, 100%.
Okay. All right.
Every time someone says like, "Can I smoke after this?" I'm like, "You should just stop smoking altogether." No, and I think I'm a millennial, so I'm seeing that a lot of people in my generation are just quitting smoking altogether. I know that a lot of younger people are into like vaping and
Yeah.
they think it's like a safer alternative, but
Uh-uh.
it really isn't.
Mm-mm.
Any kind of smoking, it's just irritation to the vocal folds. So, but I have noticed that more and more people are going away from that habit or are quitting
Yeah,
smoking.
yeah, they show it's the statistics show that. It's yeah.
Right? Have you
Yeah.
noticed that too?
Yeah, yeah, I was
I've
just
seen
looking
it.
at something recently about that, and it's just, I mean, that's one of the reasons they're saying that that's one of the big reasons that healthcare costs are falling, which I was surprised to see in the New York Times the other day, and they're saying it's because people are stopped smoking. I mean, makes perfect
Yeah.
sense.
These are
Let me ask you
so
this:
many
what about?
issues. Yeah, from smoking. Smoking can give you so many different issues,
Oh
not
God!
just, if you're
Well,
if anyone's listening.
everybody I talk to at PNI says, don't smoke, get lots of sleep,
Yeah. And
right?
for the voice, you need sleep for the voice as well. So
You need sleep
when
for
my
everything.
patients, when I get new patients, I always ask them, "Are you sleeping well? How many hours of sleep?" And they're
See,
like, "Why does that matter?"
you're all of you are on the same page about this.
That's good. I like
Yep.
that.
And I prioritize sleep ever since I started doing this podcast a few years ago. Sleep is the number one thing. One
Yeah.
more question about self care. What about alcohol and your voice? Is there any connection there?
Ooh, alcohol. That's a very controversial topic. I think
Oh,
specifically for me and my genre of music. So in mariachi, I'm sure mariachi and tequila go hand in hand, you know? And a lot of people will say, "Oh, I can't really sing. Let me take a shot." The shot will help me sing better, or it'll like warm up my
sure.
throat. Which again, a lot of times it's more of like a psychological thing. And then sometimes it's just kind of like liquid courage.
Hmm.
People are super nervous, but then they'll take the alcohol, they can relax and they can access, their instrument a little bit better. But the reality is, alcohol dries you out.
Yep.
So any kind of, excessive drinking, it's gonna dry out. And anytime the vocal folds are dry and they're coming
Mm,
together, you're singing, it's not a good combination. So I
I
always
knew
tell
it.
my patients, and then not just that, it can lead to reflux. Acid reflux is another reason why we see a lot of our patients. Reflux comes up and it goes into the throat, it irritates. And of course, alcohol consumption can lead to GERD, as they call it.
Yeah. Yeah.
So moderation, everything in moderation, I would say, except smoking. No smoking.
No
But,
smoking.
but drinking in moderation, it can be okay.
Yeah, that's what I keep reading. So I'm trying to think, is there anything we missed that you want to add?
I would say one of the things that I get a lot from my performers, and you know what, this goes in general for anyone, even people who are not professional voice users, is to learn to like the sound of your voice. A lot of my patients who come in and they're singing or they're starting to sing, and they're singing with tension and they don't notice it. And I always ask them, have you recorded yourself? Have you heard what you sound like? God, no, I hate the sound of my voice.
Everybody says that. I can't stand it either. Yeah.
Everybody says that, but
Why?
well, it's a psychological thing, but if you are, learning how to sing, if you're talking to somebody, which we all to some extent talk to people, right? If we're teaching,
Yes.
we're in a meeting. But when you really embrace your voice and you learn to love the sound of your voice, I think that's a form of self-care. Because like when people are saying like, oh, I look so ugly, or that's all it's bad for your mind to be very negative. Same thing with your voice. If you're like, oh, I hate the sound of my voice, you're just putting negative energy, so you gotta learn to love the sound of your voice. It's very much connected to who you are as a person. So I always have to teach a lot of my patients that when they come here.
That's fabulous. That is great. I'm glad we got to that. All right. Well, Romina, it's been a delight. And we'll have you on again soon, I hope.
Thank you. Thank you so much for having me.